Now, concerning the distribution, we noted that
Les antécédents qui ont été étudiés, on a vu que l'avortement, l'antécédent d'avortement était présent, c'est 39% des cas et 31% des témoins. Les IST, 76% des cas et 51% des témoins. Les cancers, les antécédents de cancer gynécologique, 15% chez les cas et 6% chez les témoins. L'accouchement dystocique, 30% des cas, 19% des témoins. La chirurgie, 14% des cas et 10% des témoins. Pour ce qui est de la contraception, on avait des proportions égales. Donc, ces résultats analysés.
these results analyzed show that there were associated factors for precancerous lesions, for example, being exposed to industrial areas was a cause. We also noted smoking as part of the reasons for contracting cancer. In conclusion, many factors were associated with precancerous lesions in women that we studied. There were accessible measures that can be taken to reduce these cancerous lesions, and we recommended the reduction of smoking, the use of appropriate products for those working in industries. We thank the partners that helped us to carry out this study. Thank you.
Great. Thank you very much. You have kept to time. So our next presenter is David Kariuki. He'll be presenting to us on the assessment of undernutrition in children aged 6 to 59 months enrolled at Doldo Sub-County Hospital in Laikipia County. Which country is that?
It's in Kenya.
From Kenya. Great, thank you.
Good morning, everyone. My name is David Karuki, and I'll be presenting on a study we did on assessment of undernutrition in children aged 6 to 59 months, enrolled at Doldo Sub-County Hospital Nutrition Clinic in Laikipia County, that's in Kenya, between 2019 and 2023. So, undernutrition occurs when there's insufficient intake of nutrients and energy. That does not mean the individual's nutrition, and usually results from disease and inadequate intake of food. It is classified into moderate and severe. That's based on measurement of Z scores and measurement of mid-upper arm circumference. Then we have the insufficient intake of nutrients and energy that does not mean the individual's usually to just from inadequate and World Bank. 149 million children were stunted in 2021. 45 million were wasted. In Kenya, as of 2023, we found that 970,000 children below 5 years were facing acute malnutrition, and 20% of children aged below 5 years were stunted. Sorry. Looking at the complications, we find that children who are undernourished are more predisposed to infections. They have impaired cognition. In the long term, we have greater risk of non-communicable disease, as well as the associated healthcare costs and reduced productivity. In our study, we aimed to look at socio-demographic factors of these children to characterize their undernutrition status and to determine trends in enrollment at the nutrition clinic. So we conducted our study in Doldo Sub-County Hospital, that's in Laikipia County in Kenya, through a retrospective analysis of records in the facility register, daily register for nutrition for children who are 15 years and below. We used the WHO growth standard tables to determine our Z scores and classify our patients. Then we used Microsoft Excel for our univariate analysis. Then we sought permission from the County Director of Health, and we identified our data. We looked at data of 341 children who were enrolled in the clinic with a median age of 24 months. The mean for height, weight, and MWAC, that's the mid-upper arm circumference, are as indicated. Looking at the sex distribution, we found that of the children enrolled, 50.4% were girls. Looking at age groups, the children aged between 6 to 23 months comprised of 45% of the children enrolled, and that called into question the methods being used in the infant and young child feeding methods, which likely could be predisposing them to being undernourished at such an early age. Characterizing undernutrition, looking at the various indicators, the wasting, underweight, and stunting, we saw that 75.9% of all the children were wasted and 31.8% were stunted. That means wasting is an indicator of acute malnutrition. That means there's likely an indication that there was food scarcity due to food insecurity in the population. Then this is a graph looking at the trends of enrollment in the clinic from 2019 to 2023. What we saw was that from 2019 to 2021, there was a decline in enrollment for all the children, and we attributed this likely one due to COVID-19 restrictions in early 2020, which disrupted the healthcare system in Kenya, including reducing the hospital attendance and also favorable weather. Then we have an increase in enrollment from 2021 to 2023, and we attributed that especially to an onset of a prolonged drought, that's in late 2020, which could have affected food scarcity, which could have affected the food security of the children. In conclusion, majority of the children were wasted, with almost half being below 2 years, and there was a notable increase in undernutrition from 2021. So we recommended that we have outreaches with screening for undernutrition, and that in the maternal and child health clinic and the nutrition clinics, there's need for education on infant and young child feeding methods. So the public health action we undertook at the hospital, that we started the measurements, that's the measurement of weight, height, and also the mid-upper arm circumference to screen for undernutrition in all children aged under 5 years for who were attending the hospital at the triage area. Thank you.
Thank you very much. Thank you very much. So our next presenter will be Kabori Yoyan. So Kabori will be presenting to us in French. You'll give us the title yourself. I'm unable to read it. Okay.
Merci, Monsieur le Modérateur.
Thank you, dear moderator, dear evaluators. My name is Béranger Kabore. I am a physician and I'm a FATP intermediate graduate from Burkina Faso. I have the honor to present a summary of our work on the factors associated with death of low birth weight neonates at the Tangadogo University Hospital Center in Burkina Faso from 2013 to 2017. According to WHO, low weight at birth concerns every newborn whose weight at birth is less than 2,500 grams. The low birth neonates are hospitalized for a long period of time for reasons including respiratory distress and food intolerance, and with 38% of death in sub-Saharan Africa. However, there is a very low treatment, and our objective is to study factors associated with death of low birth weight neonates at the Tangadogo University Hospital. Whether the low weight is due to early birth or not. So our methods. The study was conducted at the neonatology pediatry of the University Health of Tangadogo, and the period covered was 1st of January to 31st of December. And we have conducted a complete sampling of low birth weight infants, but there were no congenital malformations. We have analyzed the probability for survival, and we have conducted the Cox regression in univariate and multivariate, and we have calculated the risk ratios using Stata 14. For the model, multivariate model, we have included variables that have a significance higher than 20%, and all our tests were significant if P was lower than 0.005. In total, we have 343 low weight infants, namely 299 premature early birth children, and we also note a low survival rate as the hospitalization is continuous. And we have also noted that 60 days of hospitalization, the likelihood of survival of infants was 45%. So a premature baby out of two survives during hospitalization. With regard to factors associated with death, we have noted that premature male babies were 1.3 times likely to die compared to the premature female babies, and premature babies with survival more than 7 days were 3 times likely to die prematurely, and those who were extremely in low weight were 4 times likely to die compared to premature babies with low weight only. And premature babies showing clinical signs were 2.4 times likely to die compared to those who were taken for admission, and those who have a hemoglobin rate less than 14 grams were likely to die more than those who had hemoglobin higher than 14 grams. Survival of premature babies was lower than among babies who were born in normal conditions. So to reduce this situation, needed to admit premature babies to hospital, strengthen treatment of extreme cases of low weight, and improve the treatment of anemia. Thank you for your kind attention.
Thank you for keeping to time. So our next presenter is presenting on descriptive analysis of neonatal tetanus surveillance system in the central region of Ghana. It's in the person of Selassie Kofiche. Selassie, come to the podium, and you have 5 minutes.
Good morning, ladies and gentlemen. My name is Selassie Kofiche, presenting on evaluation of neonatal tetanus in the central region. Neonatal tetanus continues to be a public health concern in Ghana. Between 2016 and 2021, 179 deaths were recorded, and the central region contributed 3.4% of such deaths. There was limited information on literature on neonatal tetanus in the central region. Hence, we set out to do the evaluation Hence, we set out to do the evaluation to assess the system objectives and attributes, including the system usefulness. The study was carried out through cross-sectional study design. The study site is the central region with 22 districts. The system Objectives were assessed by looking at number of cases being detected and identify if there are high-risk areas within the system. Whereas the CDC updated evaluation guideline was used, among others, to assess some of these attributes: simplicity, acceptability, and sensitivity. The result was presented as charts and tables. From the assessment, majority of the respondents that were interviewed for the attribute assessment were disease control, nurses, and midwives in that order. And it was found out that the system was detecting cases. 20 cases were identified between the period of 2016 to 2021. But one interesting trend identified was from 2019 upwards, there was a decreasing case whilst deaths were increasing, which is an interesting observation. There were only 3 districts which categorically can be classified they are not high risk. According to WHO standard, TB vaccination minimum should be 80%. Sorry, I'm using a term that you are not aware of. Ewutu Senya, Upper Dentra East, and Efutu were the only districts that have met that threshold. And the corresponding districts also reporting cases are shown in the graph. With the system attribute, the major pointer I want us to identify is there is high level of data inconsistency between what has been reported into the system and what we found on the field when we went to review the registers. The results were presented. Continuous tetanus vaccination is ongoing, and chlorhexidine also is also used for cord care, which is a switch from the previous. The system was found to be acceptable, timely, fairly representative, flexible, and useful. Data quality is poor and needs improvement. The Central Regional Health Directorate is advised to train surveillance officers, and the district should do frequent visits to the study sites to help them manage their data and report as such. IDSR 3rd edition was distributed to all the study sites visited for reference use. There was a dissemination to a cross-section of staff at the Regional Health Directorate, including disease control officers. And as a prelude to the assessment, currently there is IDSR training going on for all cadre of staff across the region. This is the first group, the community-based volunteers training that have started. Thank you very much.
Thank you. So,
Merci infiniment. Nous allons à présent recueillir quelques questions pour la première partie. Et si vous avez des questions, mesdames et messieurs, veuillez lever la main pour qu'on puisse vous donner la parole. Une main, 2, 3 et 4.
so someone.
Thank you very much for the opportunity.
Merci.
Congratulate the presenters for the wonderful presentations they've done. My question goes to David. I was thinking, could you have used the composition index of anthropometric failure to give us a more detailed profile of the malnutrition status of the children instead of using the Z-score alone? Okay. Thank you.
Second question from, yes, second question.
Well, thank you. My question is for Musa. I want to know that how limit you have for his study. Limit, yes.
Okay. Third question from, was a third question there, and then the fourth one.
Excuse me, Dr. Yves from Burkina Faso. La première question, c'est pour...
The first question is addressed to Musa Ndiaye with regard to the precancerous lesions of the cervix. You have talked about a certain number of aspects for family history causes. some women are afraid if a member of family has cancer, you may be afraid that other members may have cancer. And you have also made a study using references, and the median age is 42. And so is it a matched reference case? If, and with regard to David now, you have shown a good curve with regard to COVID, but I want to know the impact of COVID on the undernutrition of children. Is it due to economic aspect? Because the impact, COVID has reduced the purchase power of households. Fourth,
Thank you. I have two questions. The first one goes to David from Kenya. In your graph, you explained to us the variations in the different rise and drop of cases of malnutrition. However, I could see that the severe cases are going down, but you did not give us the explanation for that. And second question goes to the third presenter, and on the survival curve. I would love to know those patients with a blue line, how long they were followed, and why is it flat? Is there something missing there in terms of follow-up time? Thank you.
Thank you so much. So we will take the questions in the order in which you presented, starting from Musa.
Merci beaucoup. Nous remercions.
thank you very much. We wish to thank those who were interested in the work we have presented. I received 3 questions, and the first was about the limitations of my study. The limitations that we highlighted for this study are two-pronged. First of all, the sample size, because we have conducted an exhaustive sampling for all cases, and it is the number of cases that led us to choose the reference cases. So since the number of cases was not high, that is 69, we had a very small sample. That is a limitation with regard to our study. Now, for the second question, I think I have responded to this. Was it matched? No, it wasn't. And as I said, we wanted to carry out an exhaustive collection of cases or detection of cases and conduct it randomly among women who were tested negative, in order to have a number which is double, 2 times the number of reference cases. And for the second question relating to the family history of cancer, I haven't understood it very well. So can you be a little bit specific? Because I didn't really get what you meant by using or in asking that question.
Are you able to just very straight to the point so that you can understand and answer? Is that the last question? Wait. Okay. Please, straight to the point. Very simple.
Yes. Je disais que par rapport aux antécédents familiaux, quel conseil?
With regard to family history, what advice do you have for the family? Because when a person has cancer, if, for example, one's mother has cancer, the daughter is afraid. Now, which advice will you give to the daughter? In our study, that notion of fear was not revealed with regard to those who have a family history of cancer. So we needed to look into or search for these backgrounds in order to see if in the family there were some women who had cancer. Some women were responding by yes, others no, but we really didn't delve into it to see what was their perception with regard to of cancer in the family.
So thank you for your questions. So the first question by Samuel, this was a retrospective study. So basically what we used was the data in the registers, and mostly what is captured at the facility level is the weight, the height. Of course, there's basically all the demographic data, including now, and now you add the height, weight, and the mid-upper arm circumference. So being a descriptive study, that's what we could use. We really couldn't do much because we couldn't reach out to the specific children. To the question on impact on COVID-19 on undernutrition, yes, there could be that aspect of reduced, or rather it affected the socioeconomic status of the people. However, we couldn't establish that from our registers because for us, we just looked at the enrollment in the clinic, and given the disruption that occurred as a result of COVID-19, and what happened in Kenya is we had very minimal attendance initially, and a lot of resources and a lot of attention was shifted to COVID. So in terms of reaching out to the community, conducting outreaches, it was more directed to screening for COVID, vaccinations, and so the aspect of screening for undernutrition was affected. In the registers, there's something on capturing food security. However, it's not well captured, but I believe that's among the recommendations why we say we need to have a multi-sectoral approach is because these children, in addition to just screening and telling them that they're undernutrition, we need other stakeholders to come in and maybe provide the food, and that actually has been happening. To the last question on, the severe cases going down, yes, we noted that trend, but given from the baseline in 2020, it was at 0.6, at 2023 it was 0.9. We likely attributed that to the early intervention. However, given the rising number of cases of moderate malnutrition, and you find that these children are likely, very likely can just become severely malnourished, but I don't have the exact explanation for that, but we noted that trend, and that's why we thought it's better to intervene early for those at risk and those who are moderate malnourished because it's easier to intervene. Thank you.
Merci pour la question.
Thank you for the question. The question addressed to me was a two-pronged question. That was the treatment time for all the low-weight infants. It is the same treatment time that we have used for the two categories, be it premature birth or hypertrophic birth. So as shown on the curve, it is a curve for likelihood for survival. So it shows the possibility of not dying. So below you could find the curve for premature babies who were likely to die, so a lower likelihood to live. But the curve in blue was showing low birth weight. So the curve was a little bit higher, and the period of hospitalization was relatively weak. That is why. So the curve was going up to 80 days compared to those who were born after 9 months, and after 1 month of hospitalization, they were just dismissed from hospital. A few of them would die.
Thank you very much, everybody. So I think we'll go to the. Is it a question? No, we'll have to go to the next session first. So we'll have to go to the next session. I want to be sure that Adamu is here. Adamu. Adamu is not here. Hilary. Yeah, Hilary. Okay, please come. So we'll get presentation from from 3 persons. The first person will be Hillary, followed by Teresa, and then Humphrey. They are all here. So Hillary will be presenting to us on factors associated with malaria in regions implementing case-based surveillance in Tanzania. Hillary, you have 5 minutes.
Good morning, ladies and gentlemen. My name is Hillary. I am a FELTEP resident from Tanzania. I will take you through my study titled Factors Associated with Malaria in Regions Implementing Case-Based Surveillance from August 2021 to May 2022. So globally, malaria is still a disease of concern. As per report of WHO in 2021, about 247 million cases were reported, and 93% of these were residing in Africa. But in the mainland Tanzania, over the past decade, the disease prevalence has been declining from 18.1% to 7.3%. But this, there is variations among regions. Some regions reporting up to less than 1% over the past decade to as high as 24%. So with these differences in regions, malaria stratification was conducted to enhance targeted interventions based on the risk of malaria transmission per region. So malaria case-based surveillance system was introduced in regions that were classified under very low malaria burden. So since the initiation of this system, system data hadn't yet been analyzed to enhance priorities by the Ministry of Health. So we conducted a data set analysis to find on the factors that were associated with malaria in these regions. So this was a data set analysis. We used data that was collected by the system from August 2021 to May 2022 from the regions that were classified under very low malaria strata. And these regions were cycled as shown on blue, and the ones with red color are the ones with very high disease transmission risk. So we used a checklist to collect data from the system using the malaria case registers and active case detection forms. We used this data in data analysis and applied logistic regression to determine factors associated with malaria at 95% confidence interval. So we found about 642 individuals were captured by the system, majority of who were above 16 years, and most were coming from Arusha region, and female were the most recorded, with only 24 cases equals to 4% who were found to have malaria. And those who were positive for malaria, 58% were local introduced cases. And from the regression analysis, we found that having no history of fever in the past 3 days before testing and having no history of contact with the malaria case were associated with lower odds of testing positive for malaria. So we conclude that despite the presence of local indigenous cases in these regions, we observed that majority of cases were local introduced. So we recommend the Ministry of Health to engage health stakeholders as a platform to increase community awareness and early hospital visit so as to increase early case detection as well as early active case search to enhance disease elimination by year 2030. Thank you. We acknowledge those ones.
Thank you very much for 2 minutes of your time. So the next presenter is Teresa, presenting on recent HIV infections among newly diagnosed HIV positive clients in Zimbabwe. Okay, great.
A very good morning to you all. My name is Teresa from Zimbabwe. I'm going to present to you our secondary data analysis on recent infections among newly diagnosed HIV-positive clients in Harare, Zimbabwe. The HIV case-based surveillance was piloted in Zimbabwe in 2017. 2 years later, recent testing was introduced into routine services. This test differentiates between a recent infection, that is one that has been acquired in the past 12 months, and long-term infections. This data is useful for estimating HIV incidence, understanding transmission patterns, and making public health responses in time. All this is being done so that we achieve our 95-95 targets by the end of 2030. We did a retrospective records review for the period of January 2021 to June 2022, where we included all the 687 HIV recent positive records. Our data was from two sources, the HIV Testing Services Register and the HIV Contact Tracing Register. This is a snippet showing some of the variables that we analyzed, which included the facility name, date of diagnosis, age, the profile of the patient, as well as the gender of the patient. We used Microsoft Excel for our descriptive analysis. We found out that the Southern District had the highest number of HIV-positive clients with a corresponding recent infection rate of 8.3%, while the Northern District had the least number of clients testing HIV positive. It had the highest recent infection rate of 12.4%. In overall, Harare City had an HIV recent infection rate of 8.9%. The majority of our clients were coming from the general clinic, that is to say 59.1%, followed by those coming from the antenatal care clinic at 28.8%. We had the least proportion of patients coming from the community, from the STI clinic, and from the postnatal care clinic. The majority of our respondents were female, that is 77.1%. Majority of the population were married at 66.3%. The median age in this study was 27 years. The peak age for females who had a recent positive result occurred earlier as compared to that of males. That is to say the 25 to 29 year age group for females versus the 35 to 39 year age group for males. Of the 1,413 contacts that were provided by those who were recently infected with HIV, 55.3% were tested for HIV, and of those tested for HIV, 22.5% were found to be already HIV positive, while 47.9% were newly diagnosed with HIV, and 29.6% were found to be HIV negative after testing. We concluded that males get infected late as compared to women, and we posed the question, is intergenerational sex still the driver of the HIV pandemic? We also noted that there was low testing among the contacts and also from the community. We therefore recommended targeted health education on HIV to the younger age groups, regular follow-up on outcomes of contact tracing, as well as mobilizing outreach teams to promote HIV testing in the community. Following our study, we presented these findings to the Harare City Health Directorate, as well as enhancing our contact tracing. We managed to contact trace at least 72 people during the course of our study. Thank you for paying attention.
Thank you very much for keeping to time. And our last presenter is Humphrey Banda. So if you check the records, Humphrey's name is not here, but Humphrey is supposed to be presenting here. So he'll give us the title of his presentation and proceed.
Yes.
Humphrey, you have?
Yes. Come again? Yeah, that's it. Yes. Okay. Good morning, everyone. Thank you very much. My name is Humphrey Banda. I'm a graduate from FATP Zambia. So I'm presenting the poster with the title Jacobites and Rabies Outbreak Investigation in the community of Mungwi District in Zambia, February 2023. So as of introduction, rabies is a public health concern worldwide, and it causes about 59,000 deaths every year. And in Zambia, we have had sporadic cases of rabies in various parts of the country, and it is estimated that about 40 people die from rabies every year. So we had cases of Jacobites in Mungwi district, 2 incidences, and this initiated an investigation response to determine the extent and also to determine the coverage of rabies vaccination in the area. So as of methods, we looked at the risk as those who are been bitten by jackals, and we also collected data from the veterinary department to do a data review, and also we collected some samples from the jackals and also other species like goats that were bitten. We also conducted a sensor slope analysis for the trend using R, and we also mapped the risk zones for vaccination response using QGIS. Then we also conducted tests of the samples using the direct fluorescence antibody test technique to detect rabies. So as a result, so there were 2 women and 1 goat that were bitten, and from the records, we had 227 bites, of animal bites, and of these 2 were for jackals, and 225 were dog bites. So out of these 227, only 6% of people that did not require post-exposure prophylaxis. The rest, 213, were referred for post-exposure prophylaxis. And the median age for this group in this period, it was 20, with interquartile range of 12 to 38. And it is noted that since 2019, there has not been any jackal or fox attack in this community. So the census slope was conducted in R, and it shows a trend that was reducing from 2018 to 2020, and it kept on constantly going to 2022. But what is interesting is to note that the 2 lines, the red and green, they were attached together, and this shows the risk that if you are bitten in this community, you are most likely to be bitten by a dog which is not vaccinated, and you'll be referred to have PEP for rabies. Then this one graph shows the vaccination coverage in the area, and as you can see in the graph, 2019 had about 1.6% of the vaccination, and the highest was 2022, which had about 2.2%. So for the vaccination response team, what we did is we had buffer zones that we created using the site, the normal sighting for the jackals. So we used those as central points, and we came up with 3 zones: the red zone as the high risk zone, and the orange, less risk, and the green as the least risk zone. So what the vaccination team did was they used the egg yolk vaccination strategy, where they started with the red zone vaccination using schools to do vaccination campaigns, and as they go outwards of the zones. So 3 samples were positive. The jackals where we got the samples were positive for rabies, and also one of the goats that was bitten by the jackals. So as for discussion, rabies is considered as a notifiable disease, and also this one is a management disease as considered for Zambia. So the one of the dogs are the one responsible to vaccinate the dogs. So as for conclusion, concluded that there was a presence of rabies in jackals and goats, and there was also a low vaccination coverage and high demand for PEP. And we recommended annual vaccination in dogs and also reclassifying the disease to a disease of national public importance and also enhance community sensitization. So this was the research team. Thank you very much.
Thank you very much. Humphrey wanted to benefit from the 2 minutes that Hilary gave us. Okay, so it's time for questions. If you have any question, I can see one hand there. 1, 2, 3, 4. One question per person, please. One question per person.
Bonjour à tout le monde.
Good morning, everyone. I would like to congratulate all the presenters. I have a question to Hilary, who focused on malaria. I would like to comment on the mapping that he outlined. I can see that my question about malaria, when it comes to treatment, what is the type of treatment they are giving against malaria? In the community as well, are there any strategies that were put in place to prevent malaria? Thank you. Thank you. My name is Dr. Tugma. I wanted to put a question to each of the presenters. For the first one, Hilary, one question, please. What are the type of studies that you used? You did not highlight this in your presentations. I'm putting this question to Teresa and Humphrey. Good morning, everyone. I wanted to ask a question to the Zimbabwean presenter on HIV. I wanted to know the socio-economic profile of the most affected people. Thank you. Good morning, everyone. My name is Kompare from Burkina Faso. I have a question on bites, jackal bites. What was the sampling that was done before giving out results? Thank you.
He highlighted that 94% of the patients people who were bitten, they were referred, but for PEP. But he did not give us the details. How many of these people received PEP? Because in where I come from, this is the challenge because they are paying for getting the post-exposure prophylaxis, and which is expensive, and majority of these people don't visit the facility. So I would also want to know the situation in his country. Are they paying for this post-exposure prophylaxis, or is it free?
Very good. Okay, so we'll take the responses in the order in which you presented, and kindly go straight to the point by answering the questions directly, okay? Thank you so much. So the first presenter is Hilary.
Thank you for your wonderful questions. The first question was asked about the type of treatment we are using in Tanzania. So in Tanzania, the first line treatment we currently use is artemether lumefantrine, so-called ALU, and those local cases which are found from the system are followed home, and they are given treatment by a medical personnel. They are given artemether lumefantrine. It's an oral tab. So the second question was community strategies that are in line, that are put in our setting. So at every Saturday of every month, the first Saturday of every month, it's put to have a cleanliness, the community cleanliness, in which every business is closed until 10 a.m. in order to enhance everyone participating to cleaning his or her environment, including slashing the environments to prevent mosquito reproduction and removing garbages to enhance or prevent continued mosquito reproduction. And also there are ongoing provision, free provision of mosquito nets in the community, and through RCH, Reproductive and Child Health Services, and through primary school children who act as a means of delivering the mosquito nets to their home places. Thank you.
Okay, thank you for the questions. I had 2 questions. Our study was a descriptive secondary data analysis, and the second question was on the socioeconomic profile of our clients. Unfortunately, this data is not captured in our in the data that we collect. However, most of the people that visit our public clinics, this data is from the public clinics only, are from the low to medium income group. Those of the higher group usually go to the private clinics. But however, I cannot safely say that all of them are from that group because we don't have that data. But in general, that's the case in Harare. Thank you.
Donc je ne peux pas dire que tous ces patients viennent du même groupe socio-économique, puisque les riches vont dans des cliniques et les démunis vont dans les centres de santé publique. Alors, la première question porte sur l'échantillonnage.
Sampling, because we just collected all the data that was available at the veterinary office. So the other question was on the PEP. So for the data that we used, because this was coming from the veterinary department, so we could not link this to the hospital to find out how many of those that were referred had received PEP. And basically what happens even in our country is basically the same. Sometimes you go to the hospital, they can give you the first dose for you to prepare to acquire for the next 4 doses. So basically it means they are also buying their own doses. So there's a high possibility that of these 94%, some people might not even have received the full dose. Thank you very much.
Thank you for your responses. So colleagues, we've had a lot of discussion. It has been a cocktail of topics from cervical cancer, malnutrition, prematurity, malaria, HIV. And I'm sure that we've all learned something from this. I have also learned a few things. And apart from that, there are some questions that have been generated by this discussion. What we can do is to ponder over these questions and be able to find solutions to them, so that maybe when we get the opportunity sometime later, we may be bringing the solutions to bear for discussion. I want to thank you all for paying attention, and also for the presenters for sharing their knowledge with us. The discussion will continue after this session. Thank you so much. So we have a plenary session just after this session in the plenary room. So let's all go to the plenary session now. Humphrey. We'll solve it.